A very good evening to all, and we are starting the session, Journal Club, for the month of June by IAP TVM. So we have very many eminent teachers here, and we have IAP officials here. So I'm very happy to handing over the mic to Dr. Benno, Secretary GAP, to start off this session. Over to Dr. Benno.
So thank you, Anju sir, and a very good evening to one and all. On behalf of IAP Trivandrum, I welcome all of you to this wonderful Journal Club presentation. And Journal Club, as we all know, that it's one of our flagship programs, and it has been conducted very meticulously for the past 2-3 years. And so we have a very interesting topic for today, as Anju sir had said. Topic was sensor-based electronic monitoring for asthma, randomized control trial. So we have the presenter, Dr. Shakeel Ahmed, and analysis by Dr. Dhanya Saran, and our mentor is Dr. Rekha Nair. So before we go to the actual proceedings, I would request our IAP Trivandrum President, Hariprasad sir, to give the keynote address. Over to Hariprasad sir.
Okay. Oh, thank you, Benno. At the onset, I express my sincere gratitude to Dr. Anju for meticulously carrying out this great program that's a Journal Club for the past few years. And along with that, I sincerely thank our eminent faculties, Padmanabhan sir and Ramankutty sir, for their constant support, dedication, and sincerity, and taking part in the whole discussion for the past many years. So thank you, the team. And today's program, again, it's a very, very innovative topic. And thank you, Team Gokulam, for selecting the topic and also taking part wholeheartedly in this program. So I wish this program all success. And I sincerely thank once again to all the mentors, the chairperson, as well as the Team Gokulam for taking part in this program. So over to Benno to continue the proceedings.
Thank you very much, sir, and thank you for the constant support. Next, I would like to call upon our Journal Club coordinator, Padmanabhan sir, to speak a few words.
I think I'll talk at the end after the presentation.
Okay, sir. Next, I would like to request Shaji sir to speak a few words.
Thank you so much. Kekamo.
Keka, sir.
Am I audible?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir.
Good evening. Good evening, IAP. And thank you so much. IAP faculty is very much involved in this meeting, and she is mentoring the case, and she will be doing all the. She has this is mentored by her only, and we are all the spectators. And I wish all the success in this Journal Club, and congratulating our residents and Rekha for holding the fort. Thank you so much.
Thank you, sir. And may I invite Ramankutty sir to speak a few words? Ramankutty sir.
I will speak after the paper.
Okay, sir. Okay. So I think we'll move forward. So I hand over the mic to Anju sir. Yeah.
So today's paper is a very interesting paper. We have been trying to present something from the artificial intelligence. So myself and Dr. Rekha was trying a few papers and all. Before going into the topic proper, few things that we all should know, and most of us will be knowing. The phrase artificial intelligence was coined by one person called John McCarthy, and it was in 1955. We know that artificial intelligence has got various roles in healthcare, like early detection of ailments, improving in decision making, helping in treatment, expanded access to medical services, associated care, superior experience for the patients, and wearable devices which checks the health through these devices and of course in palliative care also. And the timeline is very exhaustive, and it was a very humongous task to develop artificial intelligence tools, because the reliability depends on the maximum number of data which has been entered into the particular AI tool, that is grooming and all. So that will increase the credibility of the AI. And during this time, we have been seeing development of things like Alexa, PharmaBot, Sree, etc. and all from 1950 to 2023. and even 24. So initially itself, we knew things like ECG machines were there, which gave the diagnosis of ST elevation, anti-reward infarct, and then patient flow software have been followed by various corporate hospitals, and clinical record summary was being made and all. So whenever artificial intelligence is there, we should be knowing a few words like machine learning, deep learning, and all. So this artificial intelligence as a whole is a superficial. At the superficial level, if we go deep, we will enter the machine learning part. And again, if we go deep, there are neural networks which are similar to, as in the figure, the neuronal networks of the human brain, where the artificial intelligence thinks like a human brain. And further deep, we have got this deep learning and all. So whenever a medical AI tool is concerned, this deep learning is very important. And we know about chatbots and chat GPT and natural language processing NLP. And this large language model development has been enabled to these AI tools to talk like human quality text. And each AI tool uh, makes use of separate AI techniques like convolutional neural networks and all those things and all. And if we compare the top artificial intelligence tools in 2024, we have various tools like Analytic, Merative, Regard, Google Vertex, Preno, Iterative Health, which manages medical imaging, clinical decision support, automating clinical tasks, information retrieval, cancer detection, etc., and which have a role in diagnostic assistance also. Well, yeah, it is obvious that all these will take into account a large amount of money. It consumes a large amount of money also. And if we think about the latest things which are used in health sector, electronic medical record EMR systems with AI integrations is already there. We know about HealthFlix and all. This Partisan Health recently has been changed its name. And then decision support systems like Boya Health and Ada Health, diagnostic imaging systems, behavioral and developmental health systems like Webina, pediatrics, which makes use of pediatrics data. This is the interface of BOI, in which we give symptoms and it will give probable diagnosis and all. It is not like Google. It will delete all the negative. It will ask questions and delete the negative things. It will take the passes straight. If it is a real medical emergency, it will tell us to go to the emergency medical department. It is very, better than the Google system. What is happening in India? In India, we have many startups which have developed artificial intelligence tools. And this Niramai one is popping up more than once, which uses thermal imaging and machine learning algorithms to detect breast cancer. What is happening in Kerala? In health sector, in Amrita Institute, in KIMS and all, they have been using these, many corporate hospitals have also been using AI softwares and all. But AI pediatrics has been used by this Baby Memorial Hospital and this some of the hospitals in Kerala. And this telemedicine platforms, AI-driven diagnostic, these have been used in Kerala hospitals. Now we know that they have got many concerns like the over data leakage, privacy, safety, lack of evidence, misunderstanding, and all. But it helps in relieving certain factors like facilitating clerk duties, replacing administrative jobs, augmenting quantitative precision, reducing medical error, things like that. That's got its advantages and disadvantages. And of course, these law issues are also there. Anyway, it is obvious that more and more money is going to be put into development of this AI implementation in healthcare, and even a single some of these may start from 6 lakh units per year consumption as far as hospitals are concerned. So, will AI replace physicians? Well, for that matter, anybody? No, but people who use AI will replace those who don't. That is a big term. Now, which are the studies from India and abroad, which is based on AI and all? Artificial intelligence in child development modeling has been well studied, and it is, more like a validated thing now. And clinical decision also in artificial intelligence has been studied, and assessing the chat GPT also has been already being done. And the development of a deep learning system in detection and symptom severity in autism spectrum disorder has also been studied well. And detection of severe pediatric disease from mild symptoms. That is one study. And this is another interesting study, which we had considered for presentation also. It is a Canadian study, Canadian Healthy Infant Longitudinal Development Cohort, which predicts the pediatric asthma using machine learning. And in management of pneumonia, as well as detection of pediatric acute severe asthma in wards also, this has been used. And there is another interesting study in which there is a home monitoring of asthma exacerbation, where AI-aided stethoscope detects the bronchi and crackles and sputa, etc., which has advantage that this PF measurements can be avoided, and that's a good study, and it is very interesting. Now, in Indian pediatrics, ChatGPT, one research that has come, unraveling its significance. But in this study, it has been seen that ChatGPT has made some mistakes. Like the graded has gone to C in detecting congenital heart disease as persistent PPHN, cardiogenic shock as septic shock, UTS, pyelonephritis, etc. So that is a grade C, but we should understand that ChatGPT has got a grade of A in other conditions like cider, type 1 diabetes mellitus, etc. And I think it is too early to tell that it is good or bad, because whatever issues are there, I think people are going to work on it and better models will be available later. So Indian Pediatrics has concluded that AI should be viewed as a tool to enhance and support clinical decision making rather than a substitute for human judgment and expertise. So we have taken this study today. It's sensor-based electronic monitoring for asthma. The study has come in pediatrics, and the impact factor for the journal is 8. And it has been presented by Dr. Shakeel Ahmed, and is analyzed by Dr. Dhanya, both two enthusiastic speakers. I would like to give my gratitude to Dr. Rekha who is a mentor, and it is a very busy schedule in the hospital which is going on, and in between they have squeezed time to do this journal club for us. We also have Dr. Ramankutty sir, Emeritus Professor as an expert analysis, and Dr. Padmanabhan sir, the coordinator of the journal club for analysis center. So over to Dr. Shakeel for the presentation of the journal article. Over to Dr. Shakeel. Thank you.
Shakeel, unmute.
Sir, is the slide visible? It is visible. On the screen sharing,
Yes.
But slide sharing, slideshow. So, good evening to everyone. Today, I'll be presenting a journal which was published in the American Academy of Pediatrics on January of 2021. And the title of the journal was Sensor-Based Electronic Monitoring for the Control of Asthma, a Randomized Controlled Trial. So this test, it was basically done in Chicago in the United States of America, and it aimed at determining the efficacy of a sensor-based monitoring of daily inhaled corticosteroids and short-acting beta agonist in improving the pediatric asthma outcome. So coming to the introduction, in the United States, the asthma, it involves around 10% of the school-age children in the United States and costs approximately 82 billion annually due to missed work or school days and asthma-related healthcare use. So the daily inhaled corticosteroids, it is recommended for symptom control, but the adherence is often poor, especially among the children and the African American as well as the Hispanic population. So for many patients, the asthma control, it requires consistent use of preventive medications like inhaled corticosteroids. And so the non-adherence to ICS, it contributes to about a quarter of asthma exacerbations and over half of asthma-related complications. So the sensor-based as well as the technology in controlling the asthma, it has been developed as early as 1980s. So the sensor-based inhaler monitoring interventions have been developed to improve the ICS adherence. And the latest advances in the sensor technology, it now allows the clinicians to assess and intervene based on real-time adherence and use the data. So the integration of this sensor-based inhaler along with a mobile application, it could potentially reduce the asthma-related healthcare use, assisting patients between the healthcare provider visits. So the trial which was done in this study is called the ITRAC trial, which is the Improving Technology-Assisted Recording of Asthma Control in Children. So with this trial, what they aimed to hypothesize was an exposure to a sensor-based inhaler intervention over a period of 12 months. It would lead to significant improvements in asthma symptom control and caregiver quality of life,
as well as the reductions in the asthma-related healthcare and healthcare rates among the interventional group versus the control group. So the trial oversight, this ITRAC trial, it was a multi-site, unblinded, pre-registered, institutional review board approved randomized control trial, which was conducted from 2016 to 2017 December, and it was supported by funding from the United Health Group, a Minnesota-based managed healthcare company. So what was the main objective of this trial? It was to determine the effectiveness of a clinically integrated sensor-based inhaled monitoring intervention in improving the asthma control as well as the health outcomes among a diversity of children with moderate to severe persistent asthma in the Chicago state of United States. So coming to the inclusion criteria, the caregiver and the child dads or the bystanders, they were recruited from November 2016 to December 2017 within the 5 primary Chicago medical clinics, which included 3 primary health centers, 1 allergic center, and 1 pulmonary center. So their diagnosis, it was confirmed by the caregiver report and electronic health record or EHR verification. So for a child to be eligible for the study, they had to tick the following checklist. That is, they had to be under 4 to 17 years of age, and they had to be diagnosed with moderate to severe persistent asthma. And they should have received a prescription of daily inhaled corticosteroids for at least a year before the enrollment to the study, as per as medical record or parents' report. And they should have experienced at least 1 exacerbation requiring oral corticosteroids in the year before the trial enrollment. And the exclusion criteria was basically this app was like English inbuilt. So anyone who couldn't speak or comprehend in English, they were excluded from the study. And if the child was participating in any other smart trial, or if the child had any other conditions which can impact the asthma outcome, like chronic lung disease, cystic fibrosis, or a child who has undergone tracheostomy. So coming to the methodology, the caregiver and the child dads, they were randomly assigned in a 1:1 ratio in each clinics I mentioned before. And so a permuted block design with the blocks of 1 caregiver to 20 child dads were created, which was further stratified by the child age, the sex of the child, as well as the insurance type in which the patient was admitted. So, and an independent statistician was also introduced to allocate site-specific participation before the recruitment. So before the study personnel, they screened the potential eligible parents and the child dads via the telephone for the eligibility and the schedule, and they scheduled an intake visit. So during each intake visit, each child dad or the bystanders, they had to meet with the research team, and they completed consent forms and intake surveys via research electronic data capture, and they received a comprehensive asthma education as part of this. So the electronic surveys, they were administered to both the control as well as the interventional group at a gap of 3 months till 12 months of the study. So from this, how they were screened was that among the 1,432 caregiver and child dad screened, 17.6% were eligible to participate, and the rest 82.4% were excluded owing to the ineligibility, declining interest, and inability to verify the eligibility. And finally, the 252 caregivers, they were randomly assigned to the control group as well as the interventional group. So coming to the interventional group, these participants, they received a propeller FDA cleared inhaler sensors for inhaled corticosteroids as well as the short-acting beta agonist. And the caregivers via a mobile app and the clinicians through a provider web portal, they could monitor the child Saban daily ICS using this sensor. And this sensor was integrated with a mobile application which provided further benefits like personalized insights, encouragement, educational and counseling, surveys, and care team services. And the sensors, what they did was they tracked the medication usage, they captured the date, the time, and the number of users, and this information was received via Bluetooth, and the Bluetooth, they transmitted this data to a paired smartphone of the caregiver and the provider portal in real time. So the caregiver or the provider portal, they received alerts if the patient had, if more than 4 consecutive days of inhaled corticosteroids were missed by the patient, or if the patient was using more than 4 SABA doses per day. So the participant and provider contact via the phone calls they initiated for asthma management guidance, including the consultations, further appointments and follow-ups, medication refills, and resolving technical sensor issues. So from this picture, you can see that the sensor, it was attached to the inhaled corticosteroids. And once the child uses it or the caregiver uses it, the time and the number of puffs which were used by the child, they were received by the sensor, and via Bluetooth, it was sent to the caregiver's provider portal or the smartphone. So basically, from the study, there were 2 endpoints. It can be divided into primary as well as a secondary endpoint. The primary endpoint, it mainly involved the asthma control use, asthma symptom control, as well as the asthma healthcare use. So how was the asthma symptom control evaluated? It was evaluated based on 2 questionnaires. It can be called as asthma control test as well as childhood asthma control test. Now in the ACT questionnaires, it was a 5-item questionnaire which was administered at the baseline and at every 3 months, with scores ranging from 5 indicating a poor asthma control to a score of 20 indicating a well-controlled asthma. And the childhood ACT, it was a validated 7-item questionnaire for the child age 4 to 11 years, with a score ranging from 0 to 27. And the scores less than 19 on either scale, it indicated an uncontrolled asthma. And what was monitored was the rates of asthma-related emergency visits, hospitalizations, and OCS preparations were monitored over a 12-month trial period. Now, the secondary endpoints, it mainly emphasized upon the daily inhaled corticosteroid adherence. So for that, what the caregivers had to do was they had to affix the inhaled sensor, sync it with the Bluetooth, and ensure operability for the ICS adherence detection. So if the caregiver, if they were not aware of this, or if they failed to do all these steps, then the purpose of the study was basically defeated. And further, one more thing which was evaluated was another pediatric score, another questionnaire, which was the pediatric asthma caregivers quality of life questionnaire. As we all know that caring for a child with persistent, severe or moderate asthma, it can cause a psychological burden on the child's parents or the caretakers. So this score was also evaluated, ranging from 1 to 7, with one denoting severely impaired quality of life, and 7 was a normal quality of life, or it was unimpaired. So from this graph, you can decode that the blue ones are the control group and the black ones are the interventional group. You can see an increase of the mean ACT score significantly improved in the interference group compared to the control group. And this was the pediatric quality of life score. And here also you can appreciate that the score is significantly improved in the interventional group compared to the control group. So basically from the study, what were the interventional outcomes? The participants in the sensor-based inhaled monitoring intervention, they showed an enhanced asthma control and improved caregiver quality of life compared to the controls. So after doing the statistical analysis, the mean ACT score or asthma control score, it increased from 19.1 to 21.8 in the intervention group compared to the 19.4 to 19.9 in the control group. So what was the impact of this intervention? The interventional participants, they experienced a significant increase in ACT scores, as I've just said, including indicative of improved asthma control. And further, what they noticed was that the non-Hispanic Black participants, which accounted for the major burden of the asthma, they showed an improvement in asthma control, suggesting a potential benefit for the population with higher asthma burdens. And what they also decoded that the pediatric asthma quality of life questionnaire compared to controls was better and significantly better in the interventional group compared to the control group, indicating positive impacts on the caregiver well-being. So the one interesting thing which they noted was the healthcare use, which was seen by this patient, and they saw that there was an increase in use of hospital and emergency departments in the interventional group compared to the compared group. Now, why was that so? It was because the interventional group, they had an increased asthma awareness and knowledge with self-enhanced management support by the sensor and app, which might have led to the increased vigilance of the concerning asthma symptoms among the interventional caregivers compared to the control. So they used to visit the emergency department regularly. So now there were few limitations of the trial, like some sensors, they were incompatible with the trial, necessitating manual data entry and potentially affecting the data accuracy. And only the intervention participants, they received the sensor-based trial, hindering the comparison of medication adherence between the groups. So, and next was lack of generalizability, because since I've told in the beginning that this study was an English-based app, so the non-English speaking participants, they couldn't participate in this trial. So it limited the generalizability. And coming to the study, it was a longitudinal study and it resulted in missing data due to incomplete survey responses and sensor failures, which suggested for potential of data incompleteness. And because of all these limitations, further optimization, translation, and improved sensor reliability and battery life are warranted to address these situations and enhance the applicability of the monitoring platform. So finally, coming to the conclusion of the study, this was a randomized controls trial in which the sensor-based inhaler monitoring can improve the asthma control and caregivers' quality of life over a period of 12 months among a sample of child participants with moderate to severe persistent asthma. But although the healthcare use were significantly higher among the interventional groups compared to the control, the further intervention refinement yielded reductions in the future. The funding was by United Health Group of Minnesota, and there was no conflict of interest. Thank you.
Excellent presentation, Dr. Shakeel. Thank you for that precise and to the point presentation. Over to Dr. Dhanya Sharan for that.
I think Shakeel has to stop sharing his slides.
So slide. Slides are visible.
Same slides are.
Slides are visible. Yeah.
And if you're using the same set, it is visible. If you're using another set of slides, you have to, but the slides are visible. You can continue in the same.
Okay, ma'am.
One more, Dhanya, Dr. Shakeel, I think due to switching on, you have switched on two devices together, and they are nearby. Okay. So I think one should be, I think Dhanya madam can change her position and.
Now it's correct.
Okay. Good evening to one and all. Good evening to one and all. Today I will be analyzing the journal presented by Dr. Shakeel, Sensor-Based Electronic Monitoring for Asthma, a randomized control trial. Randomized control trial are randomized control trial are prospective studies that measure the effectiveness of a new intervention or treatment. Randomization reduces bias and provides a rigorous tool to examine cause-effect relationship between an intervention and outcome. This is because the act of randomization balances participant characteristics, both observed and unobserved, between the groups, allowing attribution of any differences in outcome to the study intervention. Randomized control trial are the gold standard in evaluating and effectively translating research data into clinical practice. The consort statement was conceptualized in order to help ascertain standardization and reproducibility of RCTs. And the consort statement is made up of 25-item checklist. It sets standard on trial design, analysis, and interpretation of the result. Now, this is the consort 2010 checklist. As you can see, it can be broadly divided into title and abstract, introduction, method, result, discussion, and other information. And there is a total of 25 questions. Now, coming to each individual part and analysis of the study. First is the title and the abstract. 1A is identification as randomized trial in the title. So in our study, the name randomized controlled trial is very much given in the title. 1B is structured summary of trial design, method, result, and conclusion. It is also clearly mentioned in our abstract. Next, coming to the introduction, 2A is scientific background and explanation of rationale. So the background is explained as studies suggest that 1 in 4 asthma exacerbations and more than half of asthma-related hospitalizations are attributable to inhaled corticosteroid non-adherence. So this study investigates the effectiveness of sensor-based inhaler monitoring in diverse pediatric population, aiming to improve asthma outcome through enhanced medication adherence and monitoring. 2B is specific objectives or hypothesis. So here the objectives are clearly given. Usually the objectives are mentioned in a question format. Here it is already explained. Evaluate if sensor-based monitoring improves asthma control, assess the impact on healthcare utilization, examine caregiver quality of life, and analyze child inhaled corticosteroid adherence. Next is the method, that is the trial design. 3A is description of trial design. So this is a randomized control trial and it is an open label study and it is a parallel design. 3B is important changes to method after trial commencement with reasons. There is no changes that was made. Next is the participants. 4A looks into eligibility criteria for the participant. As given below, the eligibility criteria was explained in detail. 4B is settings and location where the data were collected. So it was collected in 5 Chicago medical clinics, 3 primary care, 1 allergy and 1 pulmonary center. Interventions. The intervention for each group with sufficient detail to allow replication, including how and when they are actually administered. So here the intervention was inhalers sensors with electronic monitoring, and the control group was standard care without sensors, and it was given in very much detail how the sensors were monitored and how it was connected to the Bluetooth smartphones, and Shakeel had already explained about it. Now coming to the outcomes, 6A is completely, whether it is completely defined, pre-specific primary and secondary outcome measures, including how and when they were assessed. 6B is any changes to trial outcome after the trial commences. Primary outcomes and secondary outcomes are explained in detail, and there are no any changes to trial outcome after the trial has commenced. Now coming to sample size. 7A is how sample size was determined. Here the how sample size was determined is not explained in detail. And 7B is when applicable explanation of any interim analysis and stopping guideline. There was no any interim analysis or stopping guideline. Now coming to randomization and sequence generation. 8A is method used to generate the random allocation sequence. 8B is type of randomization, details of any restriction such as blocking and block size. So here it is randomly assigned in 1:1 ratio by using a permuted block design of 1 to 20 caregivers. And the ninth one is mechanism used to implement the random allocation sequence, that is also given in the study. And 10 is who generated the random allocation sequence and who enrolled participants and who assigned participant to the intervention. This is also explained in the study. Now coming to the 11th point, that is blinding. Here there is no blinding, it is an open label study. Statistical method. 12A, a statistical method used to compare groups for primary and secondary outcome. It is given in the study. 12B is method for additional analysis such as subgroup analysis and adjusted analysis, which was not done in the study. Results, participant flow. 13A, that is for each group, the number of participants who were randomly assigned and received intended treatment and were analyzed for primary outcome. 13B, for each group, losses and exclusion after randomization together with reasons. It is not detailed in the abstract and the completion rate is also unclear. And also participant flow diagram is not provided. Now recruitment. For 14A is dates defining the period of recruitment and follow-up. It is very well explained in the study that the study was conducted from 2016 to 2018. 14B is why the trial ended or was stopped. There was no our study was not end abruptly or stopped abruptly. Next is baseline data. 15, a table showing baseline demographic and clinical characteristics for each group. As you can see, the baseline demographic and clinical characteristic table was provided. Now numbers analyzed. 16 for each group, number of participants, denominator included in each analysis and whether the analysis was by original assigned group. Here the sample size is given for individual outcomes. As you can see here, sample size is provided for each individual each outcome. Now outcome and estimate. 17A for each primary and secondary outcome, result for each group and the estimated effect size and its precision, such as 95% confidence interval. 17B is for binary outcome, presentation of both absolute and relative effective size is recommended. So here, as you can see, confidence interval is already given. Axillary analysis 18, results of any other analysis performed, including subgroup analysis and adjusted analysis, distinguishing pre-specified from exploratory. So there is no subgroup analysis given. 19, there is no harm or damage explained in the study. Discussion and other information. This is the last set of in the checklist. 20 is the limitations. So as already explained, limitations are it's explained in detail, such as some inhalers were incompatible with the sensor. Also, some non-English speakers were not included in the study, and also there was some sensor failure. 21, generalizability. The generalizability of these findings to non-English speakers was limited, and so they were excluded because of lack of non-English language app. 22 is interpretation. Interpretation is given in detail in the study. So the sensor-based monitoring may improve asthma control and caregiver quality of life, but it increased the healthcare use, suggesting refinement needed. Last is 23rd is registration number and name of trial registry. It was a pre-registered study. It is the registration number is provided. Now 24 is whether the full trial protocol can be accessed and if available. So it can be accessed and the details are provided. 25 is source of funding. Source of funding is explained and including the grants that they are receiving is also explained in the study. So coming to the conclusion, the randomized control trial on sensor-based electronic monitoring for asthma provides a comprehensive assessment of the intervention's potential benefit and challenges. The study is well structured, following the consort guidelines to ensure transparency and thorough reporting. Key findings include significant improvement in asthma control and caregiver quality of life, demonstrating the potential effectiveness of electronic monitoring in pediatric asthma management. However, the increased healthcare utilization among the intervention group highlights the need for further refinement of monitoring system to optimize its cost effectiveness and overall benefit. While the study's strength include a clear focus, robust randomization, and detailed outcome measure, there are areas for improvement, particularly in reporting participant flow and sampling methods. Additionally, the increased healthcare use observed suggests a need for careful consideration of interventions, implementation, and potential unintended consequences. Overall, the study underscores the promise of technology in enhancing asthma management, but also emphasizes the necessity for ongoing evaluation and optimization to realize its benefits in diverse population. Thank you.
Thank you so much, Dr. Dhanya Sharan, for that detailed and very descriptive analysis of that article. Now, I would like to request Dr. Ramankutty sir to give his comment on the article as well as the presentation. Over to Dr. Ramankutty sir.
Hello, can you hear me?
So,
Yes, sir.
Yeah, I don't want to say much because I think it has been very well discussed. Both the paper presentation as well as the discussion is done very thoroughly. So nothing much to add. Actually, it's a clinical trial which has been, it's a classical clinical trial. Only thing is it's not blinded because it cannot be blinded. Of course, the novelty of the method is only, I mean, the study is only in the fact that they have kind of introduced technology and they have tried to assess technology for medical use. In fact, that is coming in as a big thing. Now, people really do not know how to regulate technology. There are many people advocating that algorithms, AI algorithms should also undergo official regulation like clinical trials by some body. Actually, it is not started, but they are advocating for that. So we may soon see something of that nature. In India, the Health Technology Assessment India, the HTAIN website, if you go there, you will see that there have been many studies done in India to assess technologies. Especially what I remember is one of those which assessed an algorithm for AI which reads retinal photographs so that you can eliminate the use of experts in the field. Like you don't need an ophthalmologist. You can just use a retinal camera and the AI will read and say whether and classify whether it is diabetes or not. So that kind of thing is already coming in our country. So that is coming to the particular paper. I have only two things to say. One is that one thing to note is probably the design, which, as they have mentioned correctly, it's a mixed methods design, mixed linear model, because there are two axes of analysis. One is the group, which is the group. The group comparison is there. There's also another comparison, that is a time comparison. So there are several points in which the measurements have been made. So it is not just, usually when we have clinical trials or any study, we compare groups with respect to one outcome, just one outcome. But here there are several outcomes over time. And the interesting thing about these outcomes is they are not independent outcomes, because they are occurring in the same group over time. So it is a time series, and time series classically statistics. The problem with time series is each time point is correlated with the previous time point. So there is a kind of a serial correlation among the results. So there are two axes to analyze, and that is why they have used this mixed general linear model, which is a correct way to assess. And then you will find that they have talked about interaction. Interaction means that the time element and the group element may be showing an effect on each other. What it means is that the outcome, the result the result at a particular time may depend on the time as well as the group. So it is not a parallel thing. It is actually maybe increasing with time or decreasing with time, like that. So that is what also they have looked at other possible variables like ethnicity, race, and they have found out that there is an effect modification, which means that the effect is not the same among various ethnic groups. It is not the same among various age groups, whatever things that they have looked at. It doesn't seem to be uniform. So that is also an important thing to consider, because what we find may not be true across the board. Like it may be particular for some groups, but overall there is an effect. That is what they have found. And the second point I want to emphasize, and this I am not I'm raising it as a doubt, because there is a statistically significant difference. But if you look at the difference, it's just a 10-point difference, right, between the control and the intervention. I don't know if that is so highly significant clinically. It may be,
Yeah.
but so that is an important thing that you have to discuss as clinicians. I think these are the only things I wanted to point out. Thank you.
Thank you so much, Dr. Ramankutty sir. We have Dr. Lalitha Kailas madam with us actually. I would like to request madam, if madam is okay, to give some comments regarding the presentation as well as the paper. Out to Dr. Lalitha madam.
Hi, good evening all.
Good evening,
I think both the residents have done their job well. That is, Dr. Shakeel had presented in an excellent manner. And I think Dhanya also had done the dissection. Other than that, I think regarding Ramankutty, both Ramankutty and Padmanabhan are so high intellectual. I'm not at all in a position to make a comment regarding this paper. As Dr. Ramankutty has mentioned, whether there is this 10% difference is really significant in the clinical aspect, I think it's difficult to decide. But I think that's all what I can say. Just like
Thank you, Lisa, madam.
congratulate Anju Kanmani to maintain this or carry forward this session, which is not
Thank you, madam.
really an easy task. Thank you.
Thank you so much, madam, for the kind words and that comments. And we have Dr. Shaji sir also, HOD Pediatrics Gokulam. Dr. Shaji sir, sir has to offer some comments at this point, sir. Oh, Dr. Shaji sir.
Good evening, all senior faculty members, Anju, Dr. Benno. Thank you so much for organizing such a wonderful journal club presentations. I appreciate both of our residents of Shakeel and Dhanya has done very good job under the mentorship of Dr. Rekha. They have been working on this with a very much interest and with a lot of effort to understand and decipher the journal. And by congratulate both of them and their mentors. And I appreciate Dr. Padmanabhan sir, Dr. Ramankutty sir, for giving us the expert opinion regarding this in this journal club. Thank you, Anju, for giving me the opportunity.
Thank you so much, Dr. Shai. Sir, over to Dr. Padmanabhan sir. I would like to request Dr. Padmanabhan sir to offer the comments and regarding the article.
Thank you. Only one or two things. My knowledge about this AI is very negligible, but what I have found it over the years now, if you note it, if you have a PDF, if you read any PDF article, on the right side it props up. Do you want the AI to summarize the article? I mean, give you an idea. But when I read the summary, it is totally out of. It doesn't make any sense to me. Therefore, I don't know how much AI is working, because if you read any scientific, take this article, open up in the PDF, it will prop up on the right side. AI will like to help you in summarizing and giving you the immediate points. But usually it doesn't do that way. Now, another thing which I want to point about generalizability is that here at the beginning, when they said that out of the total number of people who were asked, very many people did not participate in the study at all. Am I not right? The total number percentage who participated in the study, who were approached, was very much less. Therefore, only people who were tuned, who would be better off. It doesn't, therefore you cannot expand it to the general population further. That's what I feel, because people who were already, better tuned to go by the guidance of the doctors, they were the one who participated in the study. That's what I felt. Now, the final thing is that whenever you find that more people in a particular group is taking the health service help, their attendance in the ER is more, their attendance in the clinic is more, you cannot brush it aside and say just because they were more conscious. That is something what we want to avoid. In asthma care, long-term asthma care, we don't want them to come to the ER. Each ER visit is a failure. There's no doubt about it. You must minimize it. Here, the people who have this at more ER visit, I don't know whether this can be just brushed aside like that. And finally, regarding AI, I want to ask one question, which to Ramankutty Sree, who is going to take the responsibility? Now, the point is that I use Google Maps. Most of the time it's excellent, but sometimes it leads somewhere else, completely different place. Now, in medicine, if it makes a huge blunder, who's going to take the responsibility and who will the consumer sue? That's what I am. Because when there is a mistake, it's a huge blunder. That's what I find many times in when you use otherwise, it's just like any software. As long as it's working, it's great. But the moment it makes a mistake, it's not a small mistake it makes. When you put AI into this, and say reading retinogram, reading this, that, it makes a huge blunder. Who will be responsible?
Yeah, you have said the right thing, because that is a thing that is now being hotly debated. Now, who is responsible? Is it the doctor? Is it the company which produced the AI? Is it the programmer who coded the AI? I mean, nobody knows. So far there is no conclusion, no consensus on this. They are still discussing.
Sir, but sir, I would like to tell one point, that actually, see, the people who are using these AI tools are, I mean, they are also having, I mean, they are doing it in an intelligent way, actually. If you go to that that chat GPT thing I showed, they're actually telling you in the beginning itself, it is not equivalent to the expertise of a clinician. And if you really feel it is a medical emergency, you should go to the medical emergency department and all. So what I think when they make these things, they will definitely take care of all these things, and then only they will find all the loopholes and fit everything. And then only they will release. I mean,
yeah, that is right. Because see, you find that large language models can make a lot of mistakes. I have the same experience. When you ask ChatGPT to give you a code, it sometimes gives a nonsense code.
Yeah.
So that is really possible, and that is called, technically it's called hallucinating. The AI will hallucinate. So it's quite possible. But the thing is that it's getting slowly better. And as Anju said, right now, for instance, in radiology and all, they always say that the final word has to be by the physician, not by the AI. So the AI will help you bring out certain things.
One more thing I have heard is that, sir, if you take an AI tool, I mean, for example, in the radiology tool and all, there will be number of images which will be fed to that AI tool so that it will become foolproof and all. Now, that number of images which is put in should be very large number, so as to make that very little mistakes will be committed by the AI tool. So that is where the AI becomes very costly, and it takes humongous effort to feed all these images and all. So today, even though they may commit mistakes and all, I'm sure that a physician will not be replaced by AI, but better AIs may come. That is what I am telling, sir. I am not advocating for
it is
AI.
getting better. And to the question that Padmanabhan asked about retinal screening, I mean, that is meant as a tool for screening. I mean, it is not the final word. So since you cannot have enough ophthalmologists to go to the field and look at everybody's eye, they screen and then say pick out people, and then they probably they are brought to the clinic and then re-examined. So that way you can eliminate a lot of negatives. I think that's what they're.
But sir, but Padmanabhan sir, the question is very pertinent, because if AI makes a mistake, is the doctor responsible who used the AI responsible, or the company who has made the AI who is responsible, or the hospital who has purchased the AI who is responsible? I mean, that issue will definitely. That is very important, I think, in the long run.
Yeah, I think what
Somebody
he
will find,
said is a very relevant issue, and it's not the final word has not been spoken, because even some of the originators of AI, not only medical but general AI, like people who have been in the forefront of developing this, now they say that, please slow down, and this is going somewhere we can't even understand what it is doing. It's a black box method. So let us slow down and look at it, and then instead of jumping into putting AI everywhere. So that is really there. It's a problem, but then the thing is that it is here, it will be used. So we have to find ways of kind of taming it.
Yeah. Padmanabhan sir, shall we ask Dr. Rekha madam to give the?
Please.
Dr. Rekha madam has been, a lot of effort has been put by Dr. Rekha in discussing the, taking out the correct article, mentoring, and in between, you are seeing patients also. So, over to Dr. Rekha for the, you can add your comments on the article, journal presentation, as well as your. Yes.
We wanted to do something on artificial intelligence, but most of the studies which we saw, the methodology could not be discussed over here. It was all more like from the databases. So that is why we selected this. And as Sir said, rightly pointed out, the results at the end, it is not exactly, there is no statistically significant difference is not there. it was going, the second part was going against the hypothesis. Anyway, it was a very fruitful discussion, sir. Thank you. And with the Journal Club, actually, even as mentors, we learned quite a lot from the Journal Club. And thank you for this wonderful opportunity. I'd like to thank Anju for two things. One, giving us the opportunity, and as all the others are saying, for keeping the Journal Club going. It's quite an effort on Anju's side. And thank you, Padmanabhan sir and Ramankutty sir, for your expert opinions and for the knowledge imparted to us. I'd like to thank Shaji sir and Lalitha madam for giving all three of us the opportunity. And lastly, I'd like to thank our PGs. It's not just a duty, sir. Dhanya was actually not feeling well. She's admitted with fever. So I asked her to postpone, but she said she wanted to do it. So I really appreciate that spirit. And thank you for keeping it. Thank you, sir.
Oh, thank you, Dr. Rekha. That was a very significant, Dr. Dhanya. And we wish you become better as soon as possible. Ramankutty sir, one doubt can I ask, sir?
Yeah, sure.
Sir, we were looking, this Bluetooth sensor was actually finding out which doses which missed and all. Now, we were also talking about asthma scores based on questionnaires and all. So, can we really tell that the technology was being used? Because the questionnaire, I think the sensor had nothing to do with this questionnaire, this thing and all. So, can you just tell that by analyzing the data from the sensor, that asthma control is also good? I mean, if I'm wrong in my perception, kindly inform me.
No. If I understand you correctly, what you're saying is that only the sensor part is the innovation, right? I mean, other thing is a very straightforward study. You're using a questionnaire to assess the outcome. So it is like any other study. So there is not much of artificial intelligence here, except that it is something like a smartwatch that you're wearing, which always will monitor your heart rate, something like that. So now people are doing studies based on wearables. They take the data and see what happens to you over time and all that. It is something like that. So there is an element of technology. Apart from that, you can't really call it artificial intelligence because it's not making any decision. So that way, I think this is pretty much a straightforward study. But as Dr. Rekha pointed out, many of the other types of studies now classed as under artificial intelligence in medicine is like they are all doing it from databases, and that is probably not what I don't know, many people here may not enjoy that kind of a paper.
So one more doubt I had, sir.
Yeah. I just want to point it out.
Sir,
you are aware that there is a thing called NEJM AI. They have put out an online journal. New England Journal of Medicine has come out with an exclusive AI version. I mean, they publish all sorts of articles, and there is something called the AI Grand Rounds. It's very interesting to read. I think it is available as a podcast also. So people interested in the field can follow that. Then they will get an idea of where this is going.
Sir, one more question I wanted to ask is that we have found that the score has improved and all. Sir, is the method of checking whether that improvement was statistically significant correctly done in this article, sir?
Yes. They have not made any statistical mistake. That is properly done.
But I would like to add one thing, sir, from reading the study, what I understood, it is not much about asthma control. This is basically where the hospital wanted to monitor the adherence, basically, where the children were using it on their own. So it was a big burden on the caregivers, probably. So having a sensor, the caregivers also could have an idea about where the children were, whether the children were adhering to that. So it's basically adherence is what is being monitored, and the asthma control was based on the drug. Just like we maintain an asthma, it's a modified asthma diary. Actually,
yeah, exactly.
There is an electronic monitoring. That is all. As Sir said, it's a little bit away from artificial intelligence. But maybe next time, by that time, it will definitely go a better paper.
Before going to Hariprasad, sir, I have one doubt to Dr. Dhanya, Dr. Shakeel. Shakeel, I have one doubt here actually. I mean, it is nothing academical and all. See, this for internet and Bluetooth, you need this connectivity, right?
Yes.
So some doses can be missed, and suppose there was no electricity at that time and all. Will the sensor capture that event which has occurred and later transfer? They are not telling anything about that, right?
So this sensor actually it requires charging That's what they told about regarding the battery finally. So
Okay.
even if electricity is not there, the sensor will keep working. It's just like our mobile
Oh.
phones. So once we transfer
Yeah.
over the Bluetooth, it's just like that. But there are
Yeah.
like many
Thank you.
technical difficulties.
No, I don't know. In answer to something similar is happening. Like I don't know. I have recently installed a solar this thing in my home. So what it does is there is a device which constantly monitors what we are generating, and it is supposed to upload to the net. But then if the power fails, it will store that data for some time and upload it later. Maybe something like that will happen. I don't know.
Oh, if it is chargeable, then there are no. Anyway, the session was great. And Dr. Hariprasad, sir, could you comment, sir?
Okay, I think the present time. So thank you, Anju. Thank you, Padmanabhan sir and Ramankutty sir for taking this program forward. And I think the presentation was really excellent. Both of them performed very well, and congrats to Rekha for mentoring them. And again, I think the final message is whatever is said and done. I think if you have got a very good clinical sense, compassion, and common sense, and no artificial intelligence can replace clinician. So I think in this modern technology, I think doctors can be very safe, especially if you have got a little bit of empathy, some common sense, and a clinical sense. That is my feeling about artificial intelligence. So I think we can be probably will be the last person to be kicked out of the scenario from the profession. So that is my final message. So thank you, Anju, for this.
Thank you so much, sir. If the forum is open for discussion, and if there are any queries or any points to discuss, anybody can contribute. Otherwise, we can move on to Dr. Benno for concluding the session. Dr. Benno? Ajna sir, shall we conclude the session, sir?
Yeah, I think I can. One thing I want to say is see how they have recruited it. During intake visit, each number 252 met with the research team to complete their consent. Many people who they approached did not participate in the research. In fact, it was not a random thing. People who were more tuned to come for research came. Therefore, they don't represent the whole population. Is it not?
Generally, in any clinical trial, we can randomize only people who consent. So that will always be a selection bias.
Selection bias will be there.
But the thing is, the intervention is randomized. So you can compare the two groups. They are comparable. That's all we can say.
Sir, can we conclude, sir?
Yeah, please. Thank you.
Dr. Benno, if Dr. Benno is not there, I will.
Anju, conclude. You can conclude, Anju. Benno,
Sure, sir.
Can conclude.
Okay, sir. I want to tell one more thing, that I wanted to find out which all Kerala hospitals were using AI. And I asked the ChatGPT, and ChatGPT gave the answer, sir. Anyway.
But now the thing is that everybody will claim that they are using AI because it's become very fashionable. So
I think when computer came, every hospital was also telling that computer building like that. And it is I think this Jyotisham guys were doing AI even before now. This computer Jyotisham is also they are the persons who have
AI basically depends on whatever data you are giving. So you give any
Exactly. That's what Ramankutty I was about to say. You see, the most important thing in clinical medicine is to get the data, the patient to talk to you. Therefore, it is an art by which the clinician makes in the short time he meets with the patient, gets the data first. Now, how will this AI get the data? Unless the data is clearly given, you cannot analyze it, is it not? The most difficult part in clinical medicine is to take a history where you ask for what is relevant and get the data. I don't think AI can do it, can it? I don't know. I'm not sure. But when looking at the retina, of course, if you have fed them with, it will find out very fast. Reading radiology, it seems it is better than others. That's what they're telling. And Google chief, he was telling that with consultants he compared and he found that the AI performed better than the ophthalmologists in finding out reading diabetic retinopathy. That's what one of the
Sir,
things.
the point is, sir, in diagnosis, I mean, people are voting for AI, but for managing, sir, I think there are studies
For
which
diagnosis also it is very important, is it not? The way the relevant data is given is very important. You must know to probe into certain areas. Suppose you have a patient with a bleeding disorder, even if all the PT, APTT, everything is normal, then if there is a family history of bleeding, then you have to suspect a von Willebrand or something else. There's no screening test. Therefore, you keep on asking, do you have an auntie? Do you know what's wrong with her? Like that, you have to go on in certain aspects, you'll have to go very much into a depth. Therefore, whether the AI will ask these questions, I don't know, to the patient directly. The patient has to put in the data, am I right? Can the AI probe like we do?
sir, actually, yes, sir. It can be programmed like they can ask
Actually, it is. I mean, it's very premature to comment because it's still being developed. Recently, I heard a podcast where a person was actually experiencing, and he had lost his wife to cancer, and they were interviewing him, and he was saying that he tried many types of counseling, and the thing that he finally said was the most empathetic was an AI, not a human. He said, I could completely, I was so happy that I got into this because it was saying the right things and consoling me, and no human ever did that. So I don't know. I mean, people are very strange. So, so we may reach some kind of.
It can be programmed, sir. Yesterday I was,
exactly.
I mean, feeding. It can be programmed actually. They can ask
about data. I mean, what they're saying is, for instance, if you take X-rays, they are training the AI on millions of X-rays, like what a normal radiologist will never see in a lifetime. So 10 radiologists' lifetime of X-rays is trained on one AI. So it is very intensive, cost intensive, very. So that, I mean, you can't even compare. It's like like.
That I agree. But many times.
So I don't know if that is the right thing to do, but that is what they're doing.
See, the point is that I still remember the first third year class by Matherai sir, who said 90% of the diagnosis made on the history. I'm not talking of advanced medicine, in the OPD, in general practice. That history taking depends on you are asking question and getting the data. Will the AI be able to probe the patient and ask further questions and ask him? So suppose a patient complains of headache, will you be able to ask him whether you are having a headache in the morning, you are having a headache on Monday to say school phobia, weekend it is not there. Such questions, I mean, that's what we come to ask, is it not? That's what makes the diagnosis. But whether AI will do all that, I'm not sure. Maybe it will do better, I don't know.
No, if doctors have done that and that is available as data, then it will learn. That's all.
Okay, shall we conclude the session, sir?
Yes, please. You are asking.
Dr. Benno has come.
AI is also telling to conclude the session.
Over to Benno.
Thank you, Anju sir. And that was a wonderful discussion upon AI. And I think all the aspects, everything was being very well and detailed, had been done in a very detailed discussion. So first and foremost, I would like to thank our both postgraduates from Sree Gokulam Medical College, Dr. Shakeel Ahmed and Dr. Dhanya Saran, for the wonderful presentation. And a special mention or special thanks to Dr. Rekha Nair for wonderfully coordinating the whole session. And as Anju sir had told in the starting itself, even though it was a hectic schedule, they had somehow managed to do this journal club presentation in a very wonderful manner and very meticulously. So Rekha ma'am, a big thanks to you for coordinating it. And next, I would like to thank our expert analyst Ramankutty sir and our journal club coordinator Padmanabhan sir for conducting or for taking over the session in a very wonderful manner. And of course, our Anju K Kanmani sir, who's the backbone for the journal presentation, had, as always, doing it very wonderfully and very meticulously. And next, I would like to thank Shadi sir and Lalitha Kailas madam for giving their valuable inputs, and Hariprasad sir for joining the session and giving us all the encouragement. And last but definitely not the least, I would like to thank all the audience for the patient listening. And thank you all once again. Over to Anju sir.
Thank you. Bye.
Okay. Thank you, Ramankutty sir. Thank you, Padmanabhan sir. Thank you, Dhanya and Shakeel. Thanks, Rekha.
Will. Okay.